Welcome back, everyone. Let's begin with figure 52, which illustrates the hemodynamic changes that occur in mitral stenosis. The figure integrates the ECG, pressure tracing of the left atrium and left ventricle, and the associated heart sounds to explain the pathophysiology of the disease. First, notice the ECG at the top, which provides the timing of atrial and ventricular contractions. The large pressure tracing represents the left ventricular pressure, while the smaller tracing represents the left atrial pressure. Normally, during diastole, blood flows freely from the left atrium into the left ventricle because there's almost no pressure gradient between the two chambers. However, in mitral stenosis, the narrowed mitral valve obstructs blood flow. As a result, the left atrial pressure remains higher than the left ventricular pressure throughout diastole, creating a persistent pressure gradient. This elevated left atrial pressure is the hallmark of atrial stenosis and is responsible for pulmonary venous congestion and symptoms such as exertional dyspnea. When ventricular systole ends and the mitral valve opens, the stiff stenotic valve suddenly snaps open, producing the classic opening snap or OS. The shorter the interval between A2 and the opening snap, the more severe the mitral stenosis because elevated left atrial pressure forces the valve open early. Following the opening snap, turbulent blood flow across the narrowed mitral valve produces the characteristic low-pitched, rumbling mid-diastole murmur. Notice in the figure that the murmur gradually decreases as the pressure gradient falls during diastole. Just before the next first heart sound, atrial contraction increases left ventricular pressure once again, temporarily increasing the pressure gradient across the valve. This causes presystolic accentuation of the murmur. Remember that presystolic accentuation disappears in patients with atrial fibrillation because organized atrial contraction is absent. Also note the heart sound illustrated below the graph. S1 is loud because the thickened mitral valve closes forcefully. Opening snap follows S2, and this is followed by the diastolic rumbling murmur with presystolic accentuation. These findings, loud S1, opening snap, and the low frequency diastole rumble are the classic auscultatory features of mitral stenosis. Precordial disease. Now let's move to the next section, precordial disease, beginning with acute precarditis. Acute precarditis is an inflammatory syndrome involving the precordium with or without an associated precordial effusion. Depending on symptom duration, pericarditis is classified into 4 categories. Acute, symptoms lasting less than 4 to 6 weeks. Incessant, symptoms continue beyond 4 to 6 weeks without complete remission. Recurrent, symptoms recur after a symptom-free interval of at least 4 to 6 weeks. Chronic, inflammation persists for more than 3 months. This classification helps determine prognosis and guide treatment. Etiology of pericarditis and precordial effusion. Now, let's review the causes of acute pericarditis. The most common cause is idiopathic pericarditis, which is presumed to be viral in most patients. Importantly, identifying the exact cause is not always necessary, particularly in countries with a low prevalence of tuberculosis because most cases are benign and self-limited. Overall, confirmed the infectious causes account for only about 14% of cases. Viral causes. The most common viral pathogen is coccidiovirus A and B. Other viral causes include echovirus, parvovirus B19, Epstein-Barr virus, and HIV. Bacterial causes, although less common, but bacterial pericarditis is more severe. Common organisms include Streptococcus pneumonia, Staphylococcus aureus, Borrelia burgdorferi, causing Lyme disease, Mycobacterium tuberculosis, which remains an important cause worldwide. Fungal causes. Fungal infections are uncommon and usually occur in immunocompromised patients. Examples include histoplasmosis and blastomycosis. Post-myocardial infarction. Pericarditis may occur after myocardial infarction in two forms. The first is early post-MI pericarditis occurring within 1 to 7 days, caused by direct extension of myocardial infarction. The second is Dressler syndrome, an autoimmune process developing approximately 2 to 8 weeks after myocardial infarction. Post-cardiac surgery or procedures. Pericarditis may also develop after coronary artery bypass graft surgery, pacemaker implantation, transcatheter aortic valve replacement, and other cardiac interventions or chest trauma. Metabolic causes. Metabolic disorders include uremia, which is one of the most common metabolic causes, and hypothyroidism. Malignancies. Cancer involving the pericardium may result from Hodgkin lymphoma, breast cancer, lung cancer, renal cell carcinoma, melanoma, and other lymphomas. Autoimmune and connective tissue diseases. Autoimmune disorders include systemic lupus erythematosus, rheumatoid arthritis, polyarteritis nodosa, scleroderma. Vascular causes. Aortic dissection may produce secondary pericardial inflammation or hemorrhagic effusion. Other causes. Additional causes include drugs such as hydralazine, radiation therapy, infiltrative diseases such as sarcoidosis, vaccinations, although these are uncommon. Immune checkpoints inhibitors. Modern cancer immunotherapies may rarely cause severe immune checkpoints inhibitors associated pericarditis, which often requires immunosuppressive therapy. Clinical summary. To summarize this page, mitral stenosis produces a persistent left atrial to left ventricle diastolic pressure gradient resulting in a loud first heart sound and opening snap, and a low-pitched diastolic rumbling murmur with presystolic accentuation. Acute pericarditis is inflammation of pericardium and is classified as acute, incessant, recurrent, or chronic based on symptom duration. The majority of cases are idiopathic or viral, but clinicians should also consider bacterial, fungal, post-myocardial infarction, post-surgical, metabolic, malignant, autoimmune, vascular, drug-induced, radiation-related, and immune therapy-related causes when evaluating a patient. Understanding these etiologies is essential because treatment ranges from simple anti-inflammatory therapy for viral diseases to targeted management of underlying condition in secondary causes. Landmark trials on the right margin. Brief mention. The right margin highlights two important landmark studies. The Partner 2 trial demonstrated that transcatheter aortic valve replacements, or TAVR, provide outcomes comparable to surgical aortic valve replacement in intermediate risk patients with severe aortic stenosis. The Lampoon study introduced a technique of intentional anterior mitral leaflet laceration to reduce left ventricular outflow tract obstruction during transcatheter mitral valve replacement. These studies illustrate the growing role of structural heart interventions in modern cardiology. Let's begin with figure 52, which presents an algorithm for evaluating suspected acute pericarditis. Whenever a patient presents with symptoms suggestive of pericarditis, the initial evaluation should include physical examination, electrocardiography or ECG, chest X-ray, echocardiography, C-reactive protein or CRP, and cardiac troponin. The first question is, does the patient meet the diagnostic criteria for pericarditis? If the answer is no, if the diagnostic criteria are not satisfied, clinicians should search for alternative diagnoses such as acute myocardial infarction, pulmonary embolism, pneumonia, aortic dissection, and musculoskeletal chest pain. If the answer is yes, once acute pericarditis is diagnosed, the next step is determining whether there is a specific underlying cause or any predictor of poor prognosis. These factors determine whether the patient requires hospitalization or can be safely treated as an outpatient. Predictors of poor prognosis. The figure divides predictors into major and minor risk factors. Major predictors. These are strongly associated with complications. They include fever greater than 38 degrees Celsius, subacute onset, large pericardial effusion, cardiac tamponade, and lack of response to aspirin or NSAIDs after at least 1 week of therapy. Patients with any of these findings are considered high risk. Minor predictors. Minor predictors include myopericarditis, immunosuppression, trauma, and oral anticoagulant therapy. Although less predictive than major factors, they still warrant closer evaluation. High-risk patients. Patients with a specific suspected etiology or one or more major or minor prognostic predictors should be admitted to the hospital, undergo further etiologic investigation, and receive close monitoring for complications. Non-high-risk patients. Patients without high-risk features may receive an empirical trial of NSAID therapy. Their response determines the next step. Good response to NSAIDs, patients are considered low risk and can usually be managed with outpatient follow-up, anti-inflammatory therapy, and monitoring. Poor response, failure to improve suggests a moderate risk patient who should be admitted for further evaluation and investigations. Key point. Remember, risk stratification determines who can safely go home and who requires hospitalization. Clinical presentation, investigations, and diagnosis. Diagnosis of acute pericarditis requires at least 2 of 4 major criteria. Let's examine each one. Diagnostic criterion 1, chest pain. Chest pain is the most common presenting symptom. Typical characteristics include sharp pain, sudden onset, occasionally dull or throbbing, and often radiates to the trapezius ridge due to involvement of the phrenic nerve. The pain is pleuritic, worsened by inspiration, coughing, and sometimes hiccups. Importantly, the pain improves when the patient sits upright or leans forward, a classic feature that helps distinguish pericarditis from myocardial infarction. Diagnostic criterion 2, precardial fraction rub. The precardial fraction rub is highly specific. It is best heard with the patients leaning forward or resting on elbows and knees along the left lower sternal border. Characteristics include usually triphasic, but may also be mono or biphasic. Varies over time, therefore repeated examinations are often necessary. Although not always present when heard, it is highly diagnostic. Diagnostic criterion 3, ECG changes. Only about 60% of patients demonstrate the classic sequential ECG changes. These occur in 4 stages. Stage 1, the earliest stage, shows diffuse ST segment elevation, PR segment depression. This pattern is relatively specific for acute pericarditis. However, nearly 40% of patients may not show these classic findings. Stage 2, the ST segment normalize. The J joint returns to baseline before T-wave flattening develops. Stage 3, diffuse T-wave inversion occurs. Stage 4, the ECG gradually returns to normal. Keep in mind, changes may be diffuse or localized, and sometimes pure depression may be the only ECG abnormality. Diagnostic criterion 4, precardial effusion. The fourth criterion is new or worsening. Precardial effusion detected by imaging. Although not present in every patient, its presence strongly supports the diagnosis. Additional physical examination findings: patients may also have malaise, sinus tachycardia, low-grade fever. If the pericarditis is secondary to a systemic disease, look for findings such as rash, arthritis, weight loss, or night sweats. These clues may point toward autoimmune disease, infection, or malignancy. Laboratory investigations. Laboratory studies primarily support the diagnosis and monitor disease activity. Cardiac biomarkers. Troponin I or T is elevated in approximately 30% of patients. Elevation indicates myocardial involvement, suggesting myopericarditis or perimyocarditis. When myocardial involvement is suspected, echocardiography or cardiac MRI can provide additional information. Inflammatory markers: most patients demonstrate elevated CRP, ESR, and white blood cell count, although these markers are not specific. High sensitivity CRP is usual because persistent elevation predicts a higher risk of recurrence. Imaging. Chest X-ray findings are often normal. Heart enlargement usually becomes visible only when the pericardial effusion exceeds approximately 300 milliliter. An unexplained increase in cardiac size should always raise suspicion for acute pericarditis, especially when the long fields remain clear. Chest X-ray may also demonstrate pericardial involvement, associated pleural disease, or occasionally identify the underlying cause. Clinical pearls. Remember these high-yield examination points. Diagnosis requires 2 of 4 criteria: characteristics, chest pain, friction rub, ECG changes, or new pericardial effusion. Diffuse ST elevation with PR depression is the classic ECG finding. Chest pain improves when sitting forward. Troponin elevation suggests myocardial involvement. Elevated CRP predicts recurrence. Large effusion, tamponade, fever, or failure of NSAID therapy are major predictors of poor prognosis requiring hospitalization. Brief study of the right side clinical trial box. The page also highlights the COAPT trial evaluating transcatheter mitral valve repair in patients with heart failure and secondary mitral regurgitation. Key findings include patients receiving transcatheter mitral valve repair plus guideline-directed medical therapy experience significantly fewer heart failure hospitalization than those receiving medical therapy alone. The intervention also reduced all-cause mortality. These findings support transcatheter mitral valve repair as an effective option for appropriately selected patients with symptomatic heart failure and severe secondary mitral regurgitation. To summarize this page, acute pericarditis is diagnosed using a combination of clinical features, ECG findings, and imaging. The most important step after diagnosis is risk stratification. Patients with predictors of poor prognosis require hospitalization and etiologic investigation, whereas low-risk patients usually respond well to NSAIDs and can be safely managed as outpatients. Early recognition of complications such as cardiac tamponade and myopericarditis is essential for improving patients' outcome. After obtaining a chest X-ray, the next and most important imaging investigation is suspected acute pericarditis is echocardiography. Echocardiography is often the only image modality required. In most patients, transthoracic echocardiography TTE is sufficient, while transesophageal echocardiography TEE is reserved for selected situations when higher resolution imaging is needed. Interestingly, approximately 40% of patients have a complete normal echocardiogram, especially early in the disease. Despite this, echocardiography plays several essential roles. It identifies life-threatening complications, including cardiac tamponade and constrictive pericarditis. It evaluates for evidence of myocardial involvement, such as reduced ventricular function suggesting myopericarditis. It monitors the size of pericardial effusion and assesses the patient's response to treatment over time. During pericardiocentesis, echocardiography provides real-time guidance, improving both the safety and success of the procedure. In some patients, cardiac MRI or CT scanning can provide additional information. These modalities are particularly useful for detecting active inflammation of the pericardium and are often used when the diagnosis remains uncertain or when complications such as constrictive pericarditis are suspected. Differential diagnosis. Because chest pain is a common symptom, acute pericarditis must be distinguished from several important conditions, including Takotsubo syndrome, acute myocardial infarction, and myocarditis. Careful assessment of the clinical history, ECG findings, cardiac biomarkers, and imaging studies help differentiate these disorders. Prognosis. The prognosis of acute pericarditis depends largely on its underlying cause. The majority of patients with idiopathic or viral pericarditis recover completely and have an excellent long-term prognosis, although recurrences are relatively common. On the other hand, patients with purulent pericarditis, neoplastic pericarditis, or pericarditis associated with myocarditis have a much poorer prognosis, with reported mortality rates approaching 20 to 30%. Several major poor prognostic factors warrant hospital admission. Symptoms beginning gradually rather than acutely, fever greater than 38 degrees Celsius, a large pericardial effusion, typically more than 20 millimeters on echocardiography, evidence of cardiac tamponade, and failure to improve after 1 week of anti-inflammatory drugs. Patients with these features are at increased risk of tamponade and progression to constrictive pericarditis and therefore require closer monitoring. Additional minor poor prognostic factors include oral anticoagulant therapy, recent trauma, and immunosuppression. Treatment. The cornerstone of treatment is management of underlying cause whenever one is identified. Anti-inflammatory therapy. Anti-inflammatory medication remains the first-line treatment. NSAIDs or high-dose aspirin are the standard initial therapies because they effectively reduce both inflammation and pain. For patients with severe pain who cannot tolerate oral medications, ketorolac may be used intravenously, although treatment should generally be limited to 5 days because of potential adverse effects. Colchicine. Colchicine is now routinely added because it significantly shortens symptoms duration, reduces recurrence rate, and improves long-term outcomes. Corticosteroids. Corticosteroids are not first-line therapy because they increase the risk of recurrent disease. However, they may be appropriate when NSAIDs and colchicine are ineffective or contraindicated. The patient has autoimmune disease and pericarditis develops as a complication of immune checkpoint inhibitor therapy. Specific therapies. Management should also be directed toward the underlying etiology. Purulent pericarditis requires urgent pericardial drainage, intravenous antibiotics, and occasionally local fibrinolytic therapy. Tuberculous pericarditis requires prolonged multi-drug anti-tuberculose treatment with corticosteroids or even pericardiectomy considered in selected patients. Viral pericarditis occurring in immunocompromised individuals may require antiviral therapy. Finally, patients should avoid strenuous physical activity until symptoms have completely resolved, reducing the risk of recurrence. Complications. Although many patients recover fully, complications may occur. These include recurrent pericarditis, atrial arrhythmias, pericardial effusion, cardiac tamponade, constrictive pericarditis. These complications highlight the importance of careful follow-up after the initial episode. Pericardial effusion. We now move to the next topic, pericardial effusion. A pericardial effusion is an abnormal accumulation of fluid within the pericardial sac. Normally, the pericardial space contains only 10 to 50 milliliters of lubricating fluid that allows a smooth movement of the heart during each cardiac cycle. The accumulated fluid may consist of exudate, transudate, blood, and rarely air or gas. Etiology and classification. Many pericardial effusions are discovered incidentally during chest X-ray or echocardiography performed for unrelated reasons. In developed countries, the most common causes include idiopathic disease, accounting for up to 50%, malignancy approximately 10 to 25%, infections around 15 to 30%, iatrogenic causes such as post-procedural complications accounting for 15 to 20%, and connective tissue diseases approximately 5 to 15%. In contrast, tuberculosis remains the leading cause in many developing countries, responsible for more than 60% of cases. When a pericardial effusion occurs in association with acute pericarditis, approximately 15 to 50% are related to infectious or malignant etiologies. Pericardial effusion can be broadly divided into transudative and exudative types. Transudative effusions. These results from alternation in hydrostatic or oncotic pressure. Examples include congestive heart failure, pulmonary hypertension, cirrhosis, nephrotic syndrome, and hypoalbuminemia or severe hypoproteinemia. Exudative effusions. Exudative effusions develop because inflammation increases pericardial fluid production. Their causes overlap with those of acute pericarditis. Blood may also accumulate rapidly within the pericardial sac, producing a hemopericardium, which may result from trauma, post-myocardial infarction, ventricular free wall rupture, and aortic dissection. Finally, pericardial effusions may be classified according to time of onset, distribution, hemodynamic significance, fluid composition, and size. The clinical consequences depend not only on how much fluid accumulates, but also how rapidly it develops and whether the patient has underlying cardiac disease. A small, slowly accumulating effusion may produce few symptoms, whereas rapidly developing effusions can quickly cause cardiac tamponade, even with a relatively small fluid volume. Signs and symptoms. Let's begin with the clinical presentation. The symptoms of pericardial effusion depends primarily on how quickly the fluid accumulates rather than the absolute volume of fluid. A slowly developing large effusion may cause few symptoms, whereas a rapid accumulating small effusions can produce cardiac tamponade. Some patients remain completely asymptomatic, while others present with symptoms similar to acute pericarditis. The classic symptoms include progressive dyspnea on exertion, which may worsen to orthopnea, chest pain, especially if inflammation of the pericardium is present, and a sensation of chest fullness or pressure. As the effusion enlarges, it may compress adjacent structures outside the heart. Compression of nearby organs can produce nausea, dysphagia from esophageal compression, hoarseness due to recurrent laryngeal nerve involvement, persistent hiccups caused by by phrenic nerve irritation, tracheal or bronchial compression leading to respiratory symptoms. Patients may also develop non-specific symptoms due to reduced cardiac output or associated inflammation, including cough, generalized weakness, fatigue, loss of appetite, palpitation, fever, particularly when pericarditis is present. Physical examination. Now let's examine the important physical findings. One of the earliest findings is an elevated jugular venous pressure, often demonstrating a prominent X descent. Peripheral pulse may show normal to decreased pulse volume and reduced pulse pressure. On cardiac auscultation, you may hear distant or muffled heart sound, particularly in large effusions, and a pericardial friction rub if concurrent pericarditis exists. Another classic but less common finding is Ewart's sign. Ewart's sign consists of egophony, bronchial breath sounds, and dullness to percussion at the lower angle of the left scapula. This occurs because a large pericardial effusion compresses the left lower lobe of the lung. Many patients with the small or slowly developing effusions may have an almost normal physical examination. However, if cardiac tamponade develops, patients may present with fatigue, severe dyspnea, elevated JVP, neck vein distension, peripheral edema, pulses, paradoxus, and markedly muffled heart sound. Interestingly, friction rub are often absent once a large effusion develops because the inflamed precordial surfaces are no longer rubbing against one another. Investigations. Let's move on to the diagnostic workup. Electrocardiogram. ECG findings are often nonspecific. Common findings include sinus tachycardia, low QRS voltage, and flattened T waves. A very important ECG finding is electrical alternance, where the QRS amplitude varies beat to beat because the heart swings within a large fluid-filled precordial sac. Electrical alternance is highly specific for large precordial effusions, especially those associated with tamponade, but it is not very sensitive. A clinical pearl is that clinicians should exercise caution before diagnosing STEMI in patients with acute pericarditis and precordial effusion because unnecessary antiplatelet therapy may precipitate hemorrhagic precordial effusion. Chest X-ray. Chest radiography may demonstrate cardiomegaly, clear lung fields, and a smooth, round, water bottle-shaped cardiac silhouette in large effusions. Emergency ultrasound. In an emergency setting, bedside ultrasound using the subxiphoid view can rapidly identify fluid surrounding the heart. Echocardiography. Echocardiography is the investigation of choice. It allows clinicians confirm the presence of fluid, measure the size of the effusion, assess hemodynamic consequences, detect tamponade physiology, guide safe needle placement during pericardiocentesis. Pericardiocentesis. Pericardiocentesis serves both diagnostic and therapeutic purposes. The aspirated fluid helps determine whether the effusion is a transudate or an exudate. It also allows evaluation for infection, malignancy, and other underlying etiologies. CT and cardiac MRI. CT and cardiac MRI provides a larger field of view than echocardiography. They are particularly useful for loculated effusions, precordial thickening, masses involving the precordium, and associated thoracic abnormalities. Despite these advantages, echocardiography remains the preferred initial imaging test because it is portable, inexpensive, and readily available. Biomarkers. Inflammatory markers, especially C-reactive protein, should be measured because they help identify active inflammation and guide treatment decisions. Treatment management depends on several important factors. The first step is risk stratification, considering effusion size, hemodynamic effects, presence of tamponade, degree of inflammation, associated diseases, and these. Patients at high risk generally require hospital admission. Treat the underlying cause. Approximately 60% of pericardial effusions occur secondary or to an identifiable disease. Therefore, management should focus on treating the underlying etiology whenever possible. Anti-inflammatory therapy. If inflammatory features are present or the effusion accompanies acute pericarditis, treatment follows the pericarditis protocol. Recommended medications include aspirin, NSAIDs, and colchicine. If inflammation persists or NSAIDs are contraindicated, low-dose corticosteroids may be considered. Precardiocentesis. Drainage becomes necessary when cardiac tamponade is present. The effusion is moderate to large and symptomatic. Medical therapy has failed, and bacterial or malignant causes are suspected. Prolonged catheter drainage may reduce recurrence in patients with persistent symptomatic effusion. If a patient has a large isolated effusion without evidence of inflammation, simple precardiocentesis may be sufficient, although recurrence is relatively common. Surgical management. Some patients require surgery. Options include surgical precardial vendo, performed through a subxiphoid approach, or video-assisted thoracoscopy, pericardiectomy in selected cases. These procedures are considered when there is a recurrent fluid accumulation, loculated effusions, a need for precardial biopsy, and persistent or refractory disease. Follow-up. Patients without high-risk features may be managed with a close outpatient follow-up. Careful observation is appropriate only when there is no evidence of cardiac tamponade, bacterial infection, malignancy, elevated inflammatory markers, significant associated pathology, and large effusions greater than 20 millimeters. Follow-up should be individualized based on symptoms, effusion size, changes over time, and inflammatory marker trends. To summarize this page, the rate of fluid accumulation determines the severity of symptoms more than the total volume. Echocardiography is the diagnostic test of choice. Electrical alternance strongly suggests a large effusion with tamponade. Always evaluate for cardiac tamponade, as it is a life-threatening emergency requiring urgent drainage. Treat the underlying cause. Use anti-inflammatory therapy when inflammation is present, and perform precardiocentesis for tamponade. Symptomatic large effusions or suspected infections or malignancy. Patients without high-risk features can often be managed conservatively with careful clinical and echocardiographic follow-up. Thank you for attending the lecture. If you're new to the channel, don't forget to like and subscribe, and see you in the next lecture.